And so just to be clear, we are all here today for a training to learn about how can we assess for decisional capacity. Next slide. And my learning objectives are that you will learn a definition of capacity. You will learn about what are the different kinds of capacities. You will identify individuals who are at risk for impaired decision making. Very importantly, we will talk a lot about the core ethical tension involved when individuals or your clients, consumers, patients refuse your professional recommendations. And lastly, obviously, very importantly, how do you assess for decisional capacity in your busy professional lives? And what I failed to add was I'm also going to have a section of my talk at the very end, looking at why are we as a professional group risk averse? Why do we sometimes go beyond in protecting our clients from taking risks? Is that really person-centered? So I need to add that learning objective in the future, but thank you all for being here again. Next slide. So I really want to begin with what is capacity so that we all have a common understanding. So capacity is the functional ability, and function essentially means you're able to take an action. So it is the functional ability to make decisions, and very importantly, and to put those decisions into effect. That means you're able to carry it out. For example, you can make a functional decision. I need to take my hypertension medications 3 times a day. So you're letting your case manager know that. However, you also need to put that into effect. That means you have to be responsible for what I call medical self-management, that you will order your medication, that you will be able to take them as prescribed. So that is the carry out part. So one is, yes, I need to do it. The second part is, and I can actually do it. I can carry it out. So capacity is function specific. That means you may have the ability to decide on one specific question or area, and you may not have the ability to decide on something else. Therefore, someone can make a decision maybe about medications, but may not have the capacity to make complex financial decisions. So I really wanted to emphasize that it is function specific. Next slide. So what is the difference between capacity and competence? Now, competence is a legal construct. And when we talk about someone's competence, it is global and absolute. So it is a very binary system, or it is a binary yes or no. You have it or you don't have it. And almost always a court of law decides or determines competence. Now look at capacity, which kind of ties into what I was saying on my earlier slide. It is a clinical construct, and I'm using clinical in the broadest sense. So I'm not using it clinical in that it should only be in a mental health scope of work or a psychologist scope of work. My bottom line is it is not a legal construct, and it is viewed on a continuum versus competence is binary. So it is viewed on a continuum, or we call this a sliding scale approach. And all of us, not a judge, determines our clients, our residents, our consumers' capacity. So again, that's a very important distinction. Competence is legal, capacity is on a continuum, and we call it a sliding scale approach. That means you can have capacity at one end of that sliding scale, and you may not have it on the other end for certain areas of your life. Next slide. So again, I'm continuing with capacity and competence. So legally, you have competency, incompetency. It denotes a legal status, again, which is determined by a judge. That's why we always ask, if you're enrolling someone into your service area, that if they have a guardian, you need to ask for it, and you need to actually ask for the letter where someone was appointed as a guardian. So it donates a legal status, and the judgment is based on many things. Clinical evidence, case, and statutory law. So yes, the judge also takes into account clinical information and lay information and evidence from family members, from others who may not have the scope of work of, say, a mental health person. So the judge looks at all of it and then makes a determination. Principles of justice and other non-clinical factors are also, play a role. Because what happens is a judgment of incompetency alters one's legal status by removing what? Rights of self-determination or choice for specific matters. So what happens is, when the judge declares you incompetent, it requires transfer of decisional authority to a court-appointed proxy, either a guardian or a conservator. So you can see very clearly that the person's legal status changes. And what happens is that their rights to self-determination are abrogated, and then the court declares the need for an appointed proxy who will make all future decisions for this person. And they are either guardians, conservator, and sometimes that role can be one. Next slide. Now, did you know there are several kinds of capacities? Not competence, I'm talking about capacities. Remember I said sliding scale? So one is called testamentary capacity. That is your client's capacity to make a will, and at the time of executing the will. And the thresholds for these different capacities vary. Now, the testamentary capacity threshold is come across in my career, where we have questioned the person's ability to have executed the will because they left everything to the caregiver whom they just met 2 months ago. So one is testamentary. Second is, again, donative and contractual. Your capacity to make a gift and your capacity to understand contracts. And there have been many major cases in Oregon where someone was incapacitated and made a donative and contractual, gift to someone who was essentially duped or out of their land by some con artist. And then the family took them to court. So yes, again, do you have the capacity to make donative and contractual functions? Next is durable power of attorney. Do you have the capacity to appoint someone as your power of attorney? Very often I get calls from mental health providers, case managers, when someone is in the throes of a cognitive or a dementia crisis in the ED, and they're saying, oh, can we find a power of attorney? Nope, not when someone has advanced a dementia where it has really affected their capacity. So when someone appoints a power of attorney, they have to have the clear capacity of who they are appointing to be their power of attorney. So it cannot happen when their cognitive abilities are severely impacted. Next one is capacity to consent to medical care, to make informed healthcare decisions. This is a huge issue for many of us who work in medical and healthcare settings. Where often we are forced to work in the gray area. I call that, I can tell you many stories when I've had huge deals of moral distress, where I'm not sure my patient or my client really understands the ramification of their medical care. So do they have the capacity to make that decision? And we're going to talk a lot about this as we go along. Then the capacity to execute a healthcare advance directive. Again, do they have the capacity to know what to choose, who they want their healthcare representative to be, or are they doing it under duress because someone has, kind of hijacked their ability to make the decision, or they're unable to, but they're still being forced to. So again, you have to have the capacity to execute that. Then I have a few slides at the very end: capacity to consent to sexual relations, especially in long-term care settings. That's a huge issue, and we are going to: is it rape? Is it consensual? Is it coercion? How do you assess that? And then, this is becoming more of an issue: the capacity to drive. That is also a cognitive capacity, if you did not already know that. So can you see there are very different types of capacities with very different thresholds, in terms of legal thresholds that you have to meet. So I just wanted to bring it to your attention. And if any of you are interested, I do a training on the assessment of financial capacity, because in Oregon, that is the top area for abuse, is financial abuse. So if any of you are interested in learning more about how do you assess for financial capacity, please reach out to Angela and to Kelly. Next slide. So I'm just giving you a little teaser about financial capacity, since it is the #1 kind of abuse in Oregon. Does your client have knowledge about financial activities, such as currency? Do they know how to read their bank statements? Like, what is going in and what is going out? Do they know how to balance it? Do they know about their investments? Do they have knowledge about their financial data? Oh, I get so much from Social Security. I get so much from my pension or my investments. That's knowledge. And when I talk about currency, even showing them notes, whether they can recognize this is a $10 note, this is a $100 note. Second is skills. Ability to demonstrate practical knowledge about financial management, such as making change, writing a check, understanding a bank statement, looking at that ledger and understanding, oh, so this much came in at the beginning of the month and I wrote so many checks and this is the balance. And lastly, judgment. Ability to make reasonable and sound financial decisions in situations such as being aware of fraud, which I can give you a zillion stories where very vulnerable older adults have written over their entire life savings and their home to a caregiver whom they just met. Are they invulnerable to coercion? And are they prudent in making investments? So that is kind of just a little teaser that if you're interested in further information, but those would be the kind of things we would be looking at to see, hey, does this person have financial capacity? Next slide. And so why do we want to complete a capacity evaluation? And so many of you are here today. It helps us in getting a baseline on what is the functional impact of whatever cognitive impairment you suspect your client has. It helps you in choosing the kind of resources your client needs. If they're having problems with financial capacity, we don't need to jump to conservatorship. We can look at, is there a family member who can become power of attorney? Do we need to help set up a volunteer who can come in and help them pay their bills? So can you see it helps you with the kinds of resources you need to wrap around services. It helps you in determining whether and how to limit a client's autonomy, because they may be taking risks that can put them in harm's way without going the route of, hey, I need to have him declared incompetent. And then also a good capacity assessment helps you, all of you on your care team, allocate very sometimes scarce resources, the kind of supervision you need so that you can work more effectively with this client that you have. So those are some of the top reasons why we would do a capacity evaluation. And, I'm not going into all of the forensic reasons, there are lots of legal reasons also we do it, but for our purposes, I'm talking more about all of us who work in community-based settings. Next slide. So here are the common reasons why you would ask for a capacity assessment. Your client appears to have some level of impaired capacity. It's kind of very obvious to you, or you've seen it from their behavior that they're writing checks willy-nilly, or they failed to pay their utility bill, or there is a caregiver there who is exploiting them. For some reason, your client appears to have some level of impaired capacity, or they don't understand the medical procedure that they have been advised to have, or follow a plan. So the client is perceived to be at risk or harm or in danger due to their current situation. So whatever their current situation is, it is putting them at risk for harm or danger, such as someone whose house is packed with newspapers from the floor to the ceiling, and there is no place for them to sleep, and they're at risk for falling and breaking a hip. Or there is a fire hazard because they have, electrical wires which are not well secured. So for some reason, there's something that is putting them at harm, and that is also raising a red flag for you. Do they understand what the risk is? Very big reason: the client refuses to accept services that are offered or that could help reduce or minimize the risk. You, with all good intentions as an APD case manager or a behavioral health therapist, are telling your client and family members, we really need to put all of these safeguards in place so that we can minimize this risk. But your client says, nope, I don't want it. That's a big reason to ask for assessment. A decision has to be made whether to respect the client's rights to self-determination or to support an intervention or plan that is not consistent with your client's stated preference, or that they're unable to communicate their preference to you. So it's a very big decision for all of us who are on this training today. How do you make that decision? That, we are going to override his autonomy in favor of safety. And we're going to have that ethical discussion at the end too. Next slide. So what are some risk factors for impaired decision-making capacity? Increasing age and cognitive impairment are associated with a lack of decisional capacity. So as we go older, we can have cognitive decline. Currently, if you live up to age 85 and we don't find a cure, almost half of us on this call today will have some kind of beginning dementia. And partly dementia, as it progresses, obviously impairs several core cognitive domains, which are very important for decision making. So increasing age and having a cognitive impairment of any kind puts you at risk. Studies have shown that people with schizophrenia, which is a serious mental illness, are more likely to lack decisional capacity than those with depression, which is also a serious mental illness. Okay, so you can't just say blanket that everyone with serious mental illness lacks capacity, because first of all, that's not true. And then there are diagnoses which have a higher risk for decisional incapacity than others. And they both are, depression and schizophrenia both fall under serious mental illness. But schizophrenia, people with schizophrenia have a higher incidence of decisional incapacity than those with depression. And then among patients with psychiatric illnesses, just like what I've been telling you, lack of insight into their disease is thought to be one of the strongest predictor of lack of decisional capacity. And what do I mean by lack of insight? I don't have the disease. I don't have schizophrenia. I won't take the medications because I don't have an illness. So what can you do? That should be a very strong predictor. that if your client continues to exhibit lack of insight into this very serious illness, that it's a very strong predictor that that person lacks capacity. Next slide. So here are some additional risk factors. Any diagnosis or treatment that compromises mentation can be associated with decisional capacity. So any diagnosis and treatment that affects your brain essentially compromises mentation, including, say, chemotherapy or a brain tumor, which is, cancer, or it could be a dementia, it could be schizophrenia, but any diagnosis or any treatment that compromises mentation will lead to impaired capacity, including, say, opioids, that you're taking opioids or you're drinking alcohol. A range of severity is associated with most diagnoses. So most diagnoses, we give a qualifier: mild, moderate, severe, including dementia, including all of these serious mental illness. Hence, no diagnosis in itself is predictive of capacity. So I can't tell you with 100% certainty that everyone with schizophrenia has decisional incapacity. So you need to be aware of, what are the nuances. But look at this. Measures of neuropsychological impairment, which means performance on cognitive tests or screening tools, are among the strongest predictors of limited capacity. So if you are doing any kind of cognitive screening, not one time, but consistently, we call that serial assessment, and you're seeing kind of the same results, or you're seeing a worsening of results. So they are the strongest predictors of limited capacity. And we are going to talk about it later in this training. Next slide. So there are large groups of people who are in particular at risk, and I've given you some of them already. But here are some additional. Hospitalized older adults or adults in nursing homes, high rates between 44 and 65% have capacity problems. So if you're an older adult in the hospital or living in the nursing home, almost, between 45 and 70% will be decisionally incapacitated. Older adults with dementia, compared with healthy controls, that means older adults with no dementia, the capacity of individuals with dementia is reduced, particularly for understanding, reasoning, and appreciation. And we are going to talk about these three categories: understanding, reasoning, and appreciation. And look at that one. Patients with advanced life-threatening illnesses and on hospice. I looked at the literature, and please look at this. They were saying something like 40 or 45% of individuals on hospice lack decisional capacity. And remember, I said anything that affects your brain, anything that affects your mentation. And when they did a chart review of hospice notes, nowhere was it mentioned that we should be looking at their capacity to make decisions. So again, this should raise a red flag for any of you who work in hospice, that patients with advanced life-threatening illness and on hospice are one of those large patient groups with impaired decision-making. Next slide. So now that I've kind of given you an idea about who are these folks in terms of like a population health perspective who are at risk, I want to talk about what is risk and what is the risk of harm. So I hope you all agree with me that capacity evaluations are at heart a risk assessment. That when you raise the question about capacity, you're really raising a question about risk and are asking for a risk assessment. And what happens in this? It highlights the age-old tension between self-determination and autonomy, which is on the part of the patient, client, consumer, and your role as doing good, protection, and beneficence. So it is this kind of seesaw. How do I respect honor my patient's right to choose versus my right to do good and protect them. That is essentially at the heart of a capacity evaluation. That is essentially what a risk assessment is. How do I kind of balance this seesaw? Or should it be tipping in the favor of beneficence? Or am I so far out that it should really be tipping in favor of autonomy? Or really, it should be a combination of both. So again, if there's anything that you take back from this training today, would be this kind of ethical dilemma that we all face in our work, this tension between autonomy and beneficence. Next slide. So here is the key ethical tension. Obligation to benefit and avoid harm on your part, all of you who are on this training today, whatever your role is, versus obligation to respect the individual's right to autonomy, to bad choices, to self-determination. So can you see, how do you balance that? Are you afraid that, my gosh, if I go with what he or she wants to do, I may get into trouble? Or the family is coercing me to kind of go in favor of autonomy. Or you're going to say, you know what, I'm too busy to really explore the nuances of all this. For expediency purposes, I'm just going to say beneficence and avoid harm. So it's a constant struggle. How do you balance it? Next slide. And so I want to just give you a little background on where does this come from, this, self-determination and beneficence and all. It really comes from a very, very old doctrine, which actually was developed like in the UK, like some millennia ago, the doctrine of parens patriae, I hope I'm pronouncing the Latin correctly, which is the obligation of the sovereign, who is considered like the ultimate parent, to take care of the most vulnerable and the less fortunate in his kingdom. That's where this doctrine comes from. So the obligation of the sovereign, which is now translated into our obligation, as healthcare professionals of all kind. Two paramount principles that this doctrine highlights is autonomy and beneficence. Autonomy is the right to make decisions for yourself. It's a fundamental human right, the right to make decisions for oneself. And beneficence, which is what we all do in our professions, is the promotion of your client's well-being. And sometimes they can be in conflict. How do you reconcile that? How do you reconcile these two? And so I wanted to talk a little bit about where did this come from? And really it goes back to this concept of the sovereign as the ultimate parent who had an obligation to protect. Next slide. And no training on capacity would be complete without you understanding what are some key guiding healthcare ethics or principles, because essentially that's what we struggle with. We've already talked about beneficence, which is what we all do. Some of us are actually sworn to do it from our code of ethics, from our licensing board. But beyond that, it's not something that we are coerced to do. It is, I think, in many of our value systems, improve or maintain the quality of the person's life. Interventions should always be justified by the benefit it brings to the person, not because it's convenient to you or convenient to the family, or I have a big caseload, I cannot spend 10 hours on this one case. So any interventions has to be justified by what benefit does it bring my client. So benefit is always the measure of ethical appropriateness. So that's beneficence. Next one is non-malfeasance. Do no harm. avoid undue risk, and protect from harm. So do good is very different from do no harm. They kind of go together. But non-malfeasance is one ethical principle. The third one, which we've talked a lot about already, is autonomy, which is a fundamental human right, by the way, your right to make decisions for yourself, where you want to live, what you want to eat, what kind of medical services you want, whom you want to marry, how you want to raise your kids. That is all you expressing your autonomy. So autonomy is your right to make your decisions and to direct your life. And then the last ethical principle, which some of us get lost in, but it's a lot of what we are talking right now: social justice. You may have heard about it all over the place: equity, social justice. So the last ethical principle is justice. And next slide. And I want to just talk very briefly on justice, because many of us don't have a common language to understand it. So what is justice? Fair distribution of scarce resources. So we call it distributive justice. And right now in the news with COVID-19 and with many other things, racial inequities are in the forefront in terms of the underlying premises that we have not distributed resources fairly. So there's, and for our purposes, we are going to really look at it through the lens of capacity. So fair distribution of scarce resources. Next one is respect for all people's rights, which is rights-based justice. Whether you are an older adult with dementia, or you're a young person with schizophrenia, or you're a brilliant student at University of Oregon, that we respect all people's rights to justice. And lastly, respect for morally acceptable laws. That there are some fundamental values which are not negotiable, or they are not what I call, what's the term, relative. Like physical abuse is non-negotiable for me in my value system. It is a priority. That means it is not something we debate. It's a respectable moral stance to take across the board in all countries, in all kinds of laws. So that's respect for morally acceptable laws. So I just wanted you to understand justice, because we're going to talk, I may be bringing up some cases where we're going to look at, was it fair? Did we respect his rights? Was it morally acceptable? So what, next slide. So what is important to remember in what I've just presented are the key ethical principles are respect for adult autonomy. Children automatically, have proxy decision makers. So we are talking about adults. So respect for adult autonomy. Whoever your client is, whoever your patient is, whoever your consumer is. The central importance of decision-making capacity in determining whether personal autonomy may be overridden. How do you make a decision to limit someone's personal autonomy if you don't have a good risk assessment? And then the concept of best interest in determining a course of action when the person lacks capacity. What would be in his best interest? How can I still support his or her autonomy? So I want you to remember these key principles from all of the discussions on the sovereign as king, on the key ethical principles of self-determination, which is, beneficence, non-malfeasance, autonomy, and justice. These are the key concepts that I would like you to remember. Next slide. I also want to emphasize the components of autonomy. Remember, we talked about self-determination, right to choose, right to make decisions, right to direct your own life. What are the components? Voluntariness, choosing and acting without controlling influences. So you are choosing to act in a certain way, and there are no controlling influences, whether they be psychotic symptoms, whether they be cognitive compromise, whether there be some kind of cancer treatment that is affecting your brain, or whether you have a crooked caregiver standing on top of your head telling you to sign a will. Can you see voluntariness? That you're choosing to act without any of those controlling influences. And it's up to you to determine that. Intentionality. You have a willingness, and you're planning and you're committed to that action. So it's not hit or miss. I'll do it today, I won't do it tomorrow. Tomorrow I'll change my mind. Nope, I don't care. It is you are willing, you're planning, and you're committing to that action, whatever it is. So that's called intentionality. And lastly is that understanding and insight. What did I tell you about people with psychiatric illnesses? That lack of insight is the strongest predictor of decisional incapacity. So really having understanding and insight, that is appreciation of your situation, the choices you're making, and what implications those choices will have on your life. That is where true autonomy or true self-determination is manifested. So these are the components. So we all talk very glibly about self-direction, choice, direction. I have the ability to direct my life, but this is what's involved: voluntariness, intentionality, and understanding and insight. Next slide. So what is risk? We've been talking about, essentially this is a risk assessment. Risk is conceptualized as the potential for a negative consequence due to a variety of factors, such as the client's environmental conditions, functional limitations, or psychiatric disorders. Recently, I consulted on a complex case where the woman for years had an apartment, but she was sleeping in her shower stall, literally sleeping in the shower. I mean, there was something really wrong with that. We talk about, safety hazards in the home or functional limitations. I've had many cases where I had one woman I worked with for years in Wilsonville who had developed severe arthritis. She lived in a trailer, and she had cognitive compromise. Every time she sat in a chair or she sat on the toilet, she couldn't get up because of arthritis and also lack of cognition. She, however, remembered 911, and 911 became her rescuer, so much so that they filed a misdemeanor charge against her. So it was severe functional limitations. She had poor insight. She was unable to understand the risk. And remember that piece of justice where I talk about scarce resources? This was inappropriate use of resources, correct? Calling the 911 EMTs to pull her up from her chair or pick her up from the floor. Because she did not have the capacity to understand that she needed to move to a care setting where she would get help. So it is the potential for a negative consequence. Second is the severity of risk, the extent of harm or injury or danger or loss that is likely to occur if you don't intervene. That means how severe will be the results or outcomes or the harm to this individual if I, as a case manager, don't intervene today. And lastly, the probability of risk, the degree of certainty that you have that an outcome will occur unless action is taken. Knowing upon all of your past experience, if I don't intervene with this person today, I've seen lots of cases where the outcome has been very bad. So what you need to look at is what is risk, which is a potential for a negative consequence. What is the severity of the risk? That is the harm, injury, danger, or loss. How severe will it be? And lastly, what is the probability of the risk? What is the probability if I don't do anything that some harm is going to happen? So this is what goes into the mix in terms of you assessing the risk, kind of like an algorithm that you need to keep in your head. So here is a simple, next slide. Here is a simple slide that I have created, which is a very good way for all of you who have clients or consumers on your caseload to stratify them by risk. Stratify essentially means you're ranking them by risk. Your client who is able and willing to work with you. Those are the best kind. We all want our clients to be able and willing to work with us. The second category is they're able but unwilling. And the third one are the most difficult. They're unable and unwilling, like my woman in Wilsonville who would call 911. So this is a very simple kind of, I've put it in the vernacular, your way of kind of stratifying your caseload. Able and willing, able and unwilling, unable and unwilling. Next slide. So how do you assess for degree of risk? Remember I said we want to, what is the potential risk? What is the severity? What's the probability? Here are some good questions. What are the risk factors that you're trying to address in this particular situation? Is there anything as an acceptable or safe risk? And we're going to talk about it in the last part of this training. How long have these risk factors been present? What is different about the situation now that it's concerning you as opposed to in the past? What are the consequences associated with these risk factors? What is the probability? How significant are the consequences? That is the severity for the client and for others. Maybe it's other family members, it could be neighbors. What is the likelihood that the consequence will occur if the individual continues to refuse help? For example, what is the potential consequences for others? We had a consult on a client who was 90, had severe dementia, living alone in an apartment, would fall asleep smoking. And our fear was he lived in an apartment complex with 300 other people. Is it fair to put all of those other people at risk for a fire? So others are very important because it should factor into your decision making. And I can tell you later about that case. Next slide. So here is my definition. Risk assessment, I said at heart, a capacity assessment is a risk assessment, is the determination of the possibility of accident or danger in relation to a given situation or any existing recognized threat. However, risk assessment should not be focused simply on keeping residents safe at all costs. They should be person-centered and promote independence, choice, and autonomy, and should be regularly reviewed by staff who should have a clear understanding of the risk assessment process. And again, we are going to talk a lot about what is risk-taking in the context of a person-centered plan. Next slide. Again, remember I said it's a human right. Self-direction is a human right. So what is this person-centered approach? A person-centered approach to risk, in contrast to a traditional risk assessment, takes a balanced approach with the inbuilt assumption that the purpose of any risk assessment is just as much about the happiness of the person, the family, and the community as it is about safety. So we need to balance safety with choice. The person-centered approach to risk uses questions around a framework of purpose, people, process, and progress. This implies that we must think seriously about what we are trying to achieve before we start the assessment process. And so often we focus on the quality of care and less on the quality of life. So how do we balance that or care? Next slide. So here are some domains of risk or vulnerability that I have encountered during my 35-year experience in this field. That is basically what would raise my red flags. Decline in self-care behavior and self-protection. That means their daily living activities have kind of gone down the hill. They appear disheveled, they appear dirty, they appear to be smelling, have a strong body odor or a urine odor. And self-protection, they're not able to protect themselves from others. If, for example, I had worked with one gentleman who had deteriorated so much that he had homeless people living in his apartment. He did not know how to close his door, lock his door, or not let people in. So it was a severe decline in self-care and in self-protection. Second area is living in unsafe settings. They're unable to do just basic maintenance of their homes. There's large amounts of animal waste, uncollected garbage, electrical hazards, so lots of kind of, issues which raise a red flag for you that they are living in a very unsafe setting. This comes very often to me. Frequent exacerbations of chronic health conditions, whether it's medical or mental health. And that is what we call an instrumental activity of daily living, your ability to take care of your medical and mental health needs. I call that medical self-care. It includes managing your medication, self-monitoring of vital symptoms like blood pressure, or glucose, or wound care, if you're a diabetic. It also includes assessment of the way an individual handles acute problems, like I have chest pain, what would you do? Or practical obstacles. You run out of your medications. What are you going to do now? So this comes so often to me, especially in community dwelling elders, where it is very clear they're unable to manage what I call, medical self-care. They're unable to do that for a ton of reasons, but more often it is, their cognitive abilities are gone. And then activities of daily living, independent. Are they able to shop, prepare meals, clean, use the telephone, use transportation, make calls for their doctor's appointments, follow through on a doctor's appointment? Those are all higher level independent activities. And then everyday financial management. I've already told you that in Oregon, a financial exploitation is the #1 kind of abuse. So those are all kind of domains which would raise your red flag. Next slide. So the key question you have, all of us on this training, is my client vulnerable to harm and impairment that will limit his or her ability to continue to live safely and independently in their own home or where they choose to live? Can my client make and implement decisions for personal needs, health, and safety? Remember, I said it is not just making the decision, but also your ability to carry it out. So can your client do that? And then the big $64 million question, does my client have capacity? These are the key questions that you are raising. So next slide. And so again, I want to emphasize that capacity is twofold. One is what we call capacity assessment. That means you can make a decision. The other one is executive capacity. You can perform that decision, put it into effect, carry it out. You can say, I know I have to I have to eat 3 meals a day to stay healthy. That is a cognitive decision. Executive capacity will be, you will know how to go shopping, you will know how to budget, you will know how to bring the food back and store it in the refrigerator, you will know how to use appliances, you will know how to follow a diet if you have a special medical need. So can you see the difference? So you have to have both. And by the way, you can delegate executive capacity, and we're going to talk about it. But again, that's an ability you have to ask that I need help. Next slide. This next slide, I'm not going to go over it, but it is for your information. You can see what cognitive domains are that help us make decisions. On one side, you have learning, memory, language, attention, judgment, reasoning, speed of processing. And on the other side, you have executive functions such as planning, decision making, responding to feedback, inhibition, mental flexibility, task initiation, organization, self-regulation. All of this comprise cognitive capacity. When we talk about are you screening for cognition, it it means you're screening for all of this. So that is a whole different training, but I just wanted you to be aware what those areas were. Next slide. So if your client has capacity, or if you have capacity, you will understand, and you had to make a decision about a particular issue. You would understand the facts. You would understand the main choices. You would weigh the consequences of those choices. You would understand how the consequences affect you uniquely. And then you will clearly communicate it. So let's take this example. Right now, there's lots of what I call, what all of us are calling vaccine hesitancy. People are afraid to take the vaccine. So try applying this. And I happened to have this conversation yesterday with my dental hygienist who chose not to take the vaccine, even though our entire clinic got it. Does she understand the facts? Yes, she's well read. She understood the facts. Does she understand the main choices? That do I take it? I don't take it. And what would happen with COVID-19? Has she weighed the consequences? She says she has weighed the consequences that, she could get very ill, because if she doesn't vaccinate herself. However, she's taking, she's mitigating those. Does she understand the consequences? How it affects her uterus? She has some unique risk factors, and she's very aware that she's at a slightly higher risk level. And is she clearly able to communicate? She clearly communicated to me, I mean, this was informal, that her hesitancies around the idea that all of these vaccines came out very fast. So she doesn't know how rigorous the scientific process was. So she doesn't want to take it based on that. And she was able to meet all of those criteria for me. Now try to apply this to someone who has an impairment. So this is a very good thing to carry with you, this slide, as in your pocket, in your back pocket. Next slide. So what is capacity? The ability to understand, including risks and benefits. So this professional of mine understood the risks and understood the benefits. She said, yes, I know long-term, there's very good benefits from vaccination, but right now for me, the risks outweigh the benefits because I don't have confidence in the science. Ability to make the choice. She clearly made a choice, and she even communicated it to her employer. So can you see? So you have to understand, you need to make a choice, and then you have to communicate that choice. Next slide. What capacity is not? A requirement to act in your best interest. How many of you, all of us, have this double standard that a client should always choose the very best decision, and all of us can choose anything we want? How many of you know something is in your best interest, but you don't do it? You choose to do the opposite. We all do that. So we should extend that to our clients too. So it is not a requirement that they have to act in their best interests. A requirement to make the choice that others think you should make. Your mother wants you to make this decision, or your whole treatment team is saying this is best for you. That is not a requirement of capacity. A requirement to be able to justify your choice. You don't have to justify your everyday choices to your spouse or partner or your children. Why do we make it that we want to have our clients justify them? They don't need to. They are not children if we are working with adults. So again, capacity is not a requirement to act in one's best interest, to make a choice that others think is good for you, including team members, and they don't need to justify to you. If they have capacity, they can make bad choices, just like we all make it. Next slide. So now that we've done that backdrop, here are the 4 parts of how to assess for decision making. So this is in a nutshell: understand, appreciates, has good reasoning, makes a choice, and can communicate it. Next slide. So what do we mean by understanding? The patient needs to recall the conversations about the treatment or the intervention that you're suggesting to make the link between relationships and probabilities and outcomes. I'm using big language here, but problems with memory, attention, intelligence, any other kind of symptoms going on in your brain can affect your ability to understand. Can you see that? Appreciation. Your patient should be able to identify, it could be illness, treatment, intervention options, and the likely outcomes as things that will affect him or her directly. A lack of appreciation usually stems from a denial based on intelligence. That would be someone, say, with an intellectual disability. That means they lack the cognitive ability to understand. Emotion, or a delusion, or cognitive compromise, that they will not be able to understand, how this would impact them. That is appreciation, that you're able to appreciate all of that. Next slide. Reasoning. The patient needs to be able to weigh the risks and benefits. I was reading something about a vaccine hesitancy. They're saying we've given the wrong message. We should say live or die. That the vaccine will will give you life, and without it you'll die. So can the person actually weigh the risks and benefits of the treatment or intervention that you're offering and come to a conclusion, keeping their best interests and their values? This section of reasoning is often affected by psychosis, depression, anxiety, phobias, delirium, dementia. Can you see? And any kind of disease that affects mentation or treatment, such as chemotherapy or opioids or painkillers in high amounts in hospice. And lastly, is your ability to choose and communicate. The patient needs to be able to express the choice. And this decision needs to be stable, not that, they're vacillating. Yes, no, so that they're stable long enough for you to be able to implement it. Changing one's decision or going back and forth would raise a red flag and should raise a red flag for you that the person is having problems with capacity. Frequent changes back and forth in decision making should be indicative of an underlying either psychiatric disorder or extreme indecision, or they're just not able to make that decision if they're going back and forth. So the communication is they've looked at what you're offering them, they appreciate that particular intervention for their own situation. They have weighed the risks and benefits, and then in a very rational, clear way, they're able to communicate to you what their decision is and why. And it doesn't need to be verbal. It could be written, it could be using any kind of device, but essentially they're able to communicate that decision to you. Next slide. And here is a very good table, which I would really strongly urge all of you to copy this standalone to use as a reference point, where it kind of gives you this in a nice in a nice linear fashion, what you should be looking at. And it says physician's approach. It was written by physicians. You can put in your professional role or designation in there, and then it tells you what to look out for. Okay, so I think I included it so that you can copy it and use it as a reference. Next slide. So again, the elements of capacity are that you are able to understand relevant information as it relates to your choices you have to make. You have the ability to appreciate relevant information for one situation as effective that could be helpful. And then your ability to reason to consider and compare consequences and risks. And lastly, your ability to communicate that choice. Okay. So, next slide. And again, I've given you many slides on this, which was basically my way of reiterating it so it is etched in your memory. What are the 4 parts of decision making? First of all, you have to have the ability to receive the information. That means you should not, you should be able to hear and listen and understand. Understand the facts, appreciate the personal impact of the decision on you, then have a reasoning process for risks and benefits and predicting consequences. And lastly, you make a choice and you tell your case manager, this is what I want to do. You're not vacillating. You're not saying no, yes, because that should raise a red flag. Next slide. So here are some practical applications. Have a conversation with your client in which you present information related to the choices and see whether they possess the 4 abilities mentioned. Ask them to repeat information back to you in their own word. That means they should paraphrase it and not just parrot it or repeat it verbatim. That is one way of looking whether they understood it. And why? You have to remember, you have to pay attention, you have to be able to recall. Those are all very strong cognitive domains. Imagine if you can't remember and you can't recall, how are you going to make the decision, correct? Once you have decided that the client lacks capacity for a particular decision, assess whether they lack it in other areas. Remember that sliding scale? Even if clients lack capacity, you need to get assent from them if they cannot give consent. And that's a whole different conversation, but I wanted to put something there. So consent is more legal and medical. Assent is person-centered, that you're still getting their buy-in with whatever capacity they have. Next slide. So the next few slides I've given you some questions you can ask for the 4 areas of capacity assessment. For example, does your client understand? What is your understanding of your condition? What are the options you have for this situation? What are your understandings of the benefits? And what are the odds that this will work? What are the risks that you may have a very bad outcome? What is your understanding that if nothing is done? And I'm trying to think about my woman in the trailer, who wouldn't leave the trailer and move to an assisted living. She couldn't answer any of these questions. Next slide. To appreciate. Tell me, what do you really believe about your medical condition or your current living situation? Why do you think your case manager is recommending this for you? Do you think this is the best approach or best intervention for you? If they say yes, why? If no, why not? What do you think would happen if you accept this intervention? Or even I ask this, what would happen if you won't accept this? Where do you think you will be 1 month from now if we don't do anything? So here you're determining whether they're able to appreciate. Next slide. Reason. What factors are most important to you in deciding about this treatment? For my woman in the trailer park, she could have said, I like my independence. For me, it's very important that I have my privacy, and I'm afraid if I go into an assisted living, I'll be kind of lost in this huge kind of group of people. So what's important to you? How are you balancing the pros and the cons? Do you trust your case manager? Why or why not? That is the best interest. And what do you think will happen to you now? What would happen if you do nothing? So you're always giving them the option, but you want to explore, what do you think if we do nothing? For this lady, the one I gave you an example about, doing nothing was that she would continue to call 911 10 times a day. That is not a viable option. Next slide. and their ability to communicate and express. You've been given a lot of information about your condition. Have you decided what is best for you? Or we've discussed several choices you have. What is it that you want to do? No, I want to stay in my trailer park, and I will continue to call 911. She really couldn't understand my client. We had to, basically, the long and the short of my story was, we had to go to court to get a guardianship, to have her removed from the trailer park and placed in a, in an assisted living. And she came to me via a court mandated assessment because of that 911 misdemeanor. Next slide. More practical questions. How are you coping with XYZ? Whatever the issue is, Do you think you're having any difficulties? Why do you think this is a matter of concern to your daughter or to your son or to your doctor? What do you think we could do to address this concern? Tell me what other options there are, or what options you might want to take. Again, what are the pros and cons, or pluses and minuses of each option? And very often I would always carry a writing pad. I would actually pull it out and draw a line through the middle of the page and write pros and cons, because sometimes it's very powerful to see it written. What do these questions do? We're looking for indicators that your client can understand the information and weigh the consequences, weigh the pros and the cons, the risks and the benefits. Based on that, then they're going to make the decision, or make the decision which may not be what you want to hear, but they totally understand the decision they're making. Next slide. Remember, we talked about executive capacity. Does your client have the ability to execute or carry out or implement the decision they are making regarding their personal needs, their health, and safety? That means, do they have the capacity for self-care and self-protection? They can tell you, I need to bathe, I need to turn on the shower, but are they able to do it? It is the process of putting one's decisions into action, either alone or by delegation. Delegating it is absolutely okay. I can ask my daughter to help me get my medications from the pharmacy, or my niece comes in 3 times a week and helps prepare meals and labels them and puts them in the refrigerator. So it's absolutely okay to delegate, but you have to have the ability to delegate, correct? And executions of one decision is predicated on having a plan, adapting the plan in response to changes or unexpected circumstances, and delegating these responsible to appropriate surrogate when one is physically unable to carry out the plan. So it's very important that you also assess for executive capacity. Can they actually carry it out, as opposed to just telling you, I can do it? Next slide. And I've given you a whole bunch of screening instruments here, which can aid you or aid your team in figuring out, what's happening to your client. The get up and go or tug test is really for mobility and for falls. CATS gauges independent living activities. Lawton test is also for instrumental activities. GDS is for depression. So I've given you a whole bunch of screening instruments here, which we are not going to really look into today. Next slide. Here are some additional questions to ask. What steps would you take if you ran out of medications? Can you see that's actually executive functioning? Correct? What would happen if you stop taking your medications? Ask judgment. I'm not going over judgment. What would you do if you smelled smoke? What would you do if you had chest pains? What would happen if you did not pay your electric bill? So I've given you a whole bunch of questions that you can ask your client to gauge whether you need to be concerned about their capacity. Next slide. And when you go to home visits, be aware of all of this. Appearance, personal hygiene, and grooming. Is there soiled or spoiled food in the refrigerator or lack of food? Are there dirty dishes and sinks or medication? Are bills being paid? Or are you seeing an accumulation of unopened mail or newspapers laying right at the front door? Those are all good clues that should raise a red flag for you. Next slide. So here is our intervention, and we're going to talk some about it later too. Principle 1, when capacity is high, that means they have good capacity like you and me. The individual has a right to choice or self-determination and a right to refuse services, regardless of the level of risk or whether you agree with that decision or not, or whether the family agrees with the decision or not. 2, when the capacity is moderate and the risk is moderate, one should establish a relationship and then try to bring in those psychosocial wraparound services geared to increase capacity and decrease risk. That could be a bill payer service, a volunteer who calls them for a friendly call, maybe Meals on Wheels, trying to see if there's someone who can be a power of attorney. Those would all be kind of like mitigation measures. And then principle 3, obviously, when the capacity is low and the risk is high, we have a responsibility to step in and protect the person. These interventions may be involuntary, such as a petition for a guardianship, referral to adult protective services, or calling for a civil commitment. So there are lots of interventions that we need to be looking at. There was one woman I worked with who had lost so much weight, APS referral, that she was down to 70 pounds. And all along, people were saying choice, choice, choice. I said, no, this is dangerously low weight. That it's not a choice. Remember, we talked about the 3 components of autonomy. One was voluntariness. I said, no, she's severely depressed. And she's compromised, and we should be treating this as a medical emergency. And we did after that and transported her to the hospital. And then many years ago, there was another case that we consulted on where a man in a nursing facility was laying in his waste, in the nursing facility. And they were saying it's choice. I don't believe anyone wants to lay in their waste for 2 weeks. We finally did an assessment and decided that it was really, he was so vegetatively depressed that he was unable to make the decisions. And we transported him to the ED. And when he was transported, the mattress was stuck to his bottom because EMTs were afraid to remove the mattress because it would have pulled his skin off. It wasn't choice. It wasn't that voluntariness was missing. And subsequently, this man went on to be treated for his depression and was doing a lot better. But there, the capacity was very low and the risk was very high. Next slide. So here are some strategies I talk about to kind of optimize capacity. Really look at optimizing health and well-being. Not just health, but also well-being. Do they feel happy? Do they have a sense of a good quality of life? Are they happy? Do they have meaning and purpose? Always accommodate for any kind of sensory loss, whether it's hearing, vision, all of that, Treat underlying medical or mental health issues, all of which can compromise brain function. We've talked about alcohol and smoking that contribute to this. Very important to develop that relationship, and then always engage the support system. So here, next slide. Here I have some very basic questions you can ask to enhance collaboration using kind of like motivational interviewing questions. You ask open-ended questions, not yes or no. Then you always like reflect and summarize instead of this is what you must do. Say what ways might work for you. Can you see it's kind of more open-ended, and you're trying to solicit, what are their thoughts, what are their practical suggestions. So if you have capacity, you'll be able to say, hey, this will work for me better than that. Instead of saying the best way forward is, a better way to say it would be some choices that you have are this, this, this. And remember, they always have the choice to do nothing. Even ask them that question. What do you think would happen if we did nothing? Or where do you see yourself 1 month from now if we did nothing? So next slide. Questions to kind of talk about change. What would be the good thing about changing? What would your life be like 3 years from now or 1 month from now if you changed your problem, if you changed whatever the situation was? Why do you think others are concerned about your problem? Next slide. These are questions to ask if your client is having difficulty changing. How can I help you get past some of the difficulty you're experiencing? Or if you decide to change, what would you have to do to make this happen? Again, you're supporting autonomy. You're supporting self-determination by asking them, what do you think would need to happen? As opposed to you dictating what needs to happen. Next slide. Here are questions to ask when your client has little desire to change. Supposing you don't change, what might be the worst that can happen to you? I mean, the person could die, correct? So you're asking, what might be the worst? What is the best thing you could imagine that could result from changing? And all of you who have taken motivational interviewing training, what is really motivational interviewing? You're trying to tip the balance in favor of change, correct? So these questions, you're really using these questions to really probe, what the client wants, and then trying to use whatever they're saying to really motivate for change. So this is a question for people who don't want to change, for those unable and unwilling or able and unwilling category. Supposing you don't change, what might be the worst? Then using whatever they answer as to motivate them to change. And also, what is the best that could happen if you were to change? Next slide. And remember, I talked about cognitive screening tool that tests of neuropsychological testing was some of the strongest predictors of capacity. MMSE, which many of us don't use MMSE anymore because it's no longer in the public domain. So other instruments are equally good, like the MOCA and the SLUMS, have been found to correlate with clinical judgments of incapacity. That means your score correlates with your ability to make decisions. It has utility in identifying individuals at the high and low end of that range. It's called, we score it on 30. There is no kind of one single, I can't tell you, hey, everyone with 19/30 is decisionally incapacitated. However, we can say with some confidence, MMSE scores of less than 19, that means any score of 19 on 30 and below, whether you're using MOCA, or you're using SLUMS or anything else, are highly likely to be associated with impaired capacity. So any of you who use screening instruments on a regular basis, if you're seeing consistently that your client is getting scores below 19/30, then it should also raise a red flag. Can they be making critical decisions for themselves? Or should I be really exploring that? So yes, MMSE scores of less than 19 are highly likely to be associated with impaired capacity. And next slide, I'm just giving you the psychometric properties for both of these instruments, SLUMS and MOCA. They both are great. However, the MOCA now requires for you to go through a short training, a virtual training, and it costs $125 because they want to be sure that you are applying and administrating the instrument a uniform way. While St. Louis University mental status is totally in the public domain, you don't need to get permission or anything. So, MOCA is still pretty affordable at $125. So any of you who like the MOCA, I would strongly urge you to get online and check out that virtual training, which is not a huge time commitment. I think it's 2 hours, and then you get certified to provide this, that administer this training. Sorry, this screening instrument. Next slide. Remember, I talked about sexual consent, especially in long-term care settings. Again, here are the 3 things which I used to look for when I would do sexual consent capacity assessment, and they're coming out of the work of Peter Lichtenberg, and you will see all my resources at the end. Does the person have knowledge, reasoning, and voluntariness? Next slide. And here are some questions to ask. Are they able to demonstrate basic knowledge of sexual activities in questions and potential risks? Do they have knowledge on how to determine whether sexual activities are not desired by the partner? Do they have knowledge of appropriate time and places for sexual activities? That it's private, you can go to your room, you don't do sexual activities in the dining room. Is the individual aware of who is initiating the sexual contact? Does the individual believe that the other person is a spouse, deceased spouse, or a community living spouse, and thus acquiesces out of a delusional belief? Or are they cognizant of the other person's identity? No, that is not my deceased husband. That is Tom, whose room is next to mine. Can the individual state what level of sexual intimacy they're comfortable with? I want this, but I don't want that. Or are they really afraid and are being coerced? So these are some of the questions I would ask in determining my evaluation for capacity to consent. And by the way, for all of you on the phone, if you're interested, I do a 2-hour training on sexuality and sexual expression in long-term care settings. So you can let Angela know if you have an interest in that. Next slide. And remember, I said I've added this on to my training. Risk taking. Whose problem is it? Is it your problem or is it the client's problem? Why are we risk averse? Is there something as a positive risk? Does a risk averse practice, attitude, system, and culture often restrict a person's quality of life? Do we really balance quality of care with quality of life? And these are all reflective questions that I want you to reflect on your practice. Are we afraid of a blame culture? And I asked this of Angela earlier, before we started it. She said, yes, many people are afraid, regulatory compliance, organization, risk mitigation, strategies. Are you afraid of a blame culture, or will you go out on a bat to advocate for your client's right to undertake risk? Do we, all of us, know the difference between positive risk taking and negligent practice? For example, I'll give you an example. For many years, I was a manager of a community support services team which served people with serious mental illness such as schizophrenia. Guess what we did? Routinely, we appointed them with representative payees. That means someone else controlled their monthly income. And many of them were young people. And can you imagine how disempowering it was for someone who was 22 and 25 years old not to have control over their money? And do you know why we did it? We never did any kind of assessment on their capacity to manage their financial affairs. We did not provide them with financial literacy classes. We did not coach them on creating a budget. We just assumed they did not have that capacity. And it was frankly also expeditious, right? You have 50 clients on your case. Where do you have the time to do all of that? So let's just blanketly we'll give them a repre. We did not bother to figure out, hey, it had a fundamental effect on the person's ability of who they were, sense of who they were, that they were less than, they couldn't do it, where we failed to actually provide them with the coaching, the financial literacy, the budgeting classes. So the question is, whose risk is it? And do you know the difference between positive risk and negligent practice? Next slide. And those were reflective questions that I want you to reflect on. So this is coming out of someone from England that I really like. They called it the personal risk portfolio, or a heat map. And if you can see, on both the axes, there are high, low categories. So if you look at the first one, if they're making a decision, it says, do not allow level of risk is not related to the benefit value to so it's a low, high portfolio. If it is medium and high, can the same personal benefit be delivered in a different way by seeking some other activity? And if it's high, which is that blue category, maximize safety and risk. Management, protect the individual and manage the activity. So this is a nice, it's called a heat map for you to use with your clients. When you are trying to balance that autonomy with beneficence or non-malfeasance. Next slide. And here are some questions to ask yourself, all of us who are risk averse, using this kind of dementia risk assessment framework. And you can use it for other populations too. This comes out of the work of Clark et al., which they did it with dementia. Identify what risks are in the life context of the personal biography and everyday life of the client. So basically, know your client well. What are their physical needs, safety needs, love and belonging needs, esteem and identity needs? How many of us stop at safety needs? Never go beyond love and belonging or esteem and identity. If you don't already know about Maslow's hierarchy of need, I would urge you to pull that up. You can Google it and look at it every time you're trying to make a decision for your client or helping your client make a decision. Many of us stop at safety needs. Very few I know of go and explore what are their love and belonging needs, what are their self-esteem and identity needs. Next slide. Identify risk perspectives, which include risk to the family, to the professional, as well as to the person or your client. Keep in mind that the individual, family, and professional, organization, and general community, such as neighbors, all will have a different view of the situation. They all are coming from different viewpoints. Weighting the risk, weighing it, or considering the significance. This needs to balance the advantages and the disadvantages of allowing something to happen and include what they're calling silent risks. This involves or requires us to pay attention to whether the risks are being amplified by the individual or by the family, by society, and the awareness that this might be masking what is the actual risk. Then identify current and past strategies for managing risk. We can call this repairing risk exposure for the person with dementia. So find out, So consider how these existing patterns can be built on to enhance risk management and provide safeguards. Next slide. And here are some good questions to ask. What exactly is being proposed? What are the options we are considering? So this would be more when you're sitting down and having kind of a team approach with family members and maybe your client or consumer there. Does the person have the capacity to make this decision? Why might this matter to the person, whatever is at stake? How much is doing it, not doing it, likely to impact their quality of life? And I think very often many of us fail to ask that. What are the specific risks? How likely are they to happen? What level of harm is likely? Remember, we talked about what is risk, the severity of risk, and the probability of risk. That's what you're exploring here. What are the potential risks and benefits to the family, caregivers, and the wider community? Remember, not to the client, but to the family, caregivers, and the wider community. Next slide. What are your own fears as a professional and others? For example, being blamed if things go wrong. That is that blame culture. Or kind of regulatory oppression. What ideas do we have for doing what the person wants and reducing the risk? Have you explored ideas that maybe this is what they want, but how can we help him or her still do it but reduce the risk? Number 8, what's the bottom line? What are the rules or conditions that we all have to agree to follow? And what is the contingency plan if things go wrong? So what is your bottom line? Create that bottom line if you don't have one. What roles and responsibilities do each of us have? Is there anyone else we need to involve who's missing? And 10, what changes should trigger a review for this decision? Hey, we are going to go with this decision, but here are 1, 2, 3. If these should occur, we should all get back to the table and review it. Next slide. Here I've given you a list of more formal decision-making tools which are used by neuropsychologists and other licensed folk. This is just for your information that I put them there. And then next slide. This is the Oregon Surrogate Statute in a medical emergency, okay? Only in a medical emergency where you are at the brink of dying. They first look for the guardian. If they can't or there's no one, they look at the spouse. If that is not there, any adult acceptable to those listed above, there's some kind of adult, their friend or something. Then it is the majority of available adult children. After that, it's parents. Then it is available adult siblings. Then it is other friends and relatives. And finally, it is the physician who can make that life and death decision. But many people are kind of surprised that spouse has legal authority over adult children and parents. And the children of the person who is at risk have a legal authority over the parents of that person. So I'm just giving you what is Arrogance Statute, and this is kind of common in all states. In fact, about 3 times in my career, and mostly when I was at the state hospital, worked in Missouri, where we invoked this, and the physician made the life and death decision. In my case, all 3 cases, the person needed emergency surgery. One was for cancer, one was for some other kind of, injury, where they were, because of their psychosis, were unable to make that decision. No guardian, no family members. And so we went with the medical director of the state hospital, made the decision or gave the consent for the surgery. Next slide is just for your information included. This is kind of a decision tree on what you should be doing to to come to a decision to make a capacity assessment. And the next slide. And the next 4 slides are all of my resources. Please take a moment to explore them. There are lots of them there. And then the very last slide is my thanks to all of you for being such a great audience and sticking it out with me for these 2 hours. We have some time for questions now. So if we can remove my PowerPoint, and 3 of us can just go to a gallery view. I am very happy, Angela and Kelly, to take questions. I'm hoping, my hope is that I've introduced you to the topic of capacity, and that from all its different angles, including risk aversion, and that moving forward, you will be able to use and apply this in your work. Thank you for being such a great audience. So Angela, are there any questions or comments?
Nirmala, we do have quite a few questions.
Okay.
We have one from Paul Salatino. How does IQ level correspond to capacity?
So I clearly said that, your intellectual ability is definitely taken into account. I can't give you any kind of cutoff for it, but if you look at what is the cutoff for IDD, I think it's around like 70 or below. You would definitely want to engage in that conversation. Again, remember, I'm not talking about competence, I'm talking about capacity. Your individual with a 73 IQ may be able to make everyday decisions about what they want to eat, or where they want to go, or what kind of clothes they want to wear. They may not have the capacity to make decisions which are much more nuanced about medical treatment and medications, etc. So, there's no clear cutoff, but definitely I routinely ask for capacity assessments when I am working with people with intellectual and developmental disabilities, and want to have, more understanding about their abilities.
Okay, our next question is from Jennifer Linton. Who does those assessments to determine capacity?
Good.
Do I have the ability to do that?
So if you're going for formal testing, because it is required, say, by the courts, or you are required you're seeking guardianship, generally you can either get it from a neuropsychologist who does neuropsychological testing. On the other hand, I was trained, I'm a licensed clinical social worker. Much of my career was spent in Clackamas County Behavioral Health as the geriatric mental health specialist. I routinely did capacity assessments too, very often mandated by the court. My little lady from Wilsonville in the trailer, I did the assessment on her. And so it is really, the neuropsychologists, generally, those are very expensive reports because it involves 4 to 5 hours of testing, and very often people don't have that capacity. On the other hand, like I said, I have, I have been doing that all my life. So at least last 20 years. So.
Great. We have from Julia Freeman. How, if at all, do the standards of capacity differ internationally versus in the US? And is there more reported instances of males, females, or non-binary adults being abused when it comes to capacity across sectors?
Like I said, the right to self-determination is a human right. So it's across the world. Different cultures construct, what values are important to them. Like in our Western cultures, self-determination and autonomy is given precedence over anything else. But in many countries in Africa and Asia, that is not the leading principle. They all have more of a group orientation, where autonomy and self-determination is not on the top of the totem pole. In fact, having a group orientation is actually valued. But regardless of that, the right to self-determination is a human right. That means if you want to exert your right to how you want to live your life, the international community states it's a human right. However, we know that is not the case across the world. In many countries, um, women, for example, with no mental compromise, are still considered second-class citizens, and their decisions have to be subjugated to either their husband or their family. So I don't know how to answer it, but if you're talking in terms of the groups we addressed, again, there are lots of variations to how people with disability are treated across the world. Again, it can be culture bound, but I subscribe to the notion that it is a human right to be treated with dignity.
Next, we have Jennifer Wells. I believe it may just be more of a comment. It's been in her experience working in the field that when there are safety concerns and a very clear indication that someone does not have capacity, that there are no community supports or resources to intervene.
And I totally agree with you. Especially with an aging population. In Oregon, currently 18% of our population is older adults. That means 65 plus. And in 9 short years, we will be up to 22 to 25%. That means, 1 in 4. And I don't think we are building the community resources at the same rate as our population is aging. And remember, I said aging is a risk factor. So I totally agree with you that there are limited resources chasing this huge need, and very often there is nothing out there. And I've had some sad scenarios where people who were definitely cognitively compromised were kind of discharged to the street. So I don't know how to address it, except all of us should be raising our voices as advocates for services for vulnerable people.
Okay, our next one, Sherry Story. Does capacity have to be sustained beyond the current moment? If a person is consistent with their decision, understanding, appreciating, reasoning, and communicating choice, but does not recall the decision 2 days later, are they still considered to have capacity?
Nope, then I would question it. Because remember, part of capacity is you have to have the ability to have memory, recall, retention. Those are all cognitive domains. So how can you be making an informed decision if you can't remember? Correct?
Okay. Sonia Hedinger, is there consideration for consistency of capacity?
I told you capacity is on a sliding scale. So if you're consistent in what you want to do in one area, I would say you have capacity. If you're vacillating, going back and forth, you're unsure, you change your mind in the morning and you do something else in the evening, that should raise a red flag for you. That the person is having a hard time making a decision and sticking with it. Because how can you implement it if you're changing it so frequently?
Okay, our next one from Sarah Guest. I'm curious about psychiatric and mental health therapy resources for older adults with impaired ability or dual diagnosis in Crook County.
Very good question. As a system of care, mental health, OHA has funded this initiative, which is bringing you the training today. Our hope is that as more people attend these trainings, we provided on a variety of topics, that mental health providers will be much more able to provide the kind of treatment that older adults need. But currently, I would say it is far and few between, not just in Crook County, but across Oregon. And that's why this initiative was born. So part of this training is what we call workforce development, that we are hoping to develop a workforce of the future that will be better able to serve the behavioral health needs of older adults.
And can I just point out, hi everybody, it's Angela again. Sorry about the technical problems. For Crook County specifically, you have got several teams for community that range from community emergency outreach to jail diversion through Best Care. So Sarah, my apologies if you are with Best Care. If you are, then I think Nirmala's answer is what you're looking for. If you're not familiar with the systems there, then there are a few things in the community. Reach out to me personally at my email and we can connect around this if you would like some more help in making those connections. Thanks.
Anything else, Kelly?
Okay, let's go to Shanita. If an individual was referred to APS and is no guardian for this person who needs skilled care, what can you suggest a service provider do? What can be done if this person has been given the right to make decisions, even though this person is high risk and unable to make choice for safety and health?
So my suggestion would be to see if anyone can do a capacity assessment on this person. That would be one. If they are in danger for themselves, like in dire danger, even considering maybe a civil commitment, if that's an option in your county. But really, the bottom line is to have that kind of capacity assessment, and you don't have to go the route of a neuropsychologist or something. Anyone on your team, if they have the capacity to do an assessment, giving clear indicators why you think that this person lacks capacity, then I don't know what your ability is to pursue a guardianship. That would be the route to go. But if they have the capacity, they can make the baddest choice they want to make. And what you need to do is you need to document that this person has the capacity. However, they're choosing to make bad choices, and we have counseled them. We've talked about the risks, but they have a right to do that.
I'm actually familiar with that case with Shanita, and we're talking about a paranoid schizophrenic who will not take her medications. So I think we definitely have the capacity, consent, and guardianship issue.
Right. And we already said that people with psychiatric illness, especially those that lack insight, are at high risk for decisional incapacity.
Okay, our next question from Clayton Halverson. Who would be the best person in a care facility or someone to bring into a care facility to conduct these types of evaluations? When should an evaluation be done to avoid actual problems?
Now, here is the issue. There are very few geriatric mental health specialists at the county community level. I happen to be with Clackamas County Behavioral Health. I was hired for that, and so I would go into facilities. But not all community mental health programs have someone who's trained to do it. So unfortunately, you're not going to like my answer. It's very difficult to get someone to do it. My suggestion would be, at the very least, to check in with your older adult behavioral health specialist like Angela. All counties have one such person. At the very least, consult with them and see what other resources there may be for you.
Okay, next one from Heather Shipley. Is there a gold standard for mental health advance directive form or format? One that will hold up as capacity is compromised?
No, it's the standard advance directive, mental health advance directive. There is no other form. It's the one that is legally approved.
But can't you write that in narrative that if family or your designated health provider notices declining capacity, that you want XYZ done, that then your wife, your spouse
have to abide by the advance directive, because the the assumption is that it was written when the person had capacity.
Correct. And as I read the question, it was, can you write something in, can you make modifications to the advance directive to include issues around declining capacity for yourself?
So you cannot, the client who is writing it can include that. That if I should decline in my capacity, appoint my mother to make decisions for me. But it's them doing it, not you as a treatment lead or something.
Correct.
Yeah.
Correct.
Yes.
That's
Absolutely, you can say that, if I'm incapacitated due to a psychotic relapse, I'm going to ask my mother, give her name to make decisions on my behalf for my treatment.
Thanks for the question, Heather.
Do we have time for one more?
One more, and then I have to call it a day because I have to prepare for my next meeting.
So from Maria Aranda, sadly, adult protective services is a voluntary service. Therefore, for older adults that lack capacity, often decline services. What can we do to protect those folks? Pursue conservatorship?
So, you pursue conservatorship only if there's financial exploitation. And you're clearly stating that they lack financial capacity and will continue to squander off their assets in a irresponsible way because they're compromised. So yes, pursue conservatorship, absolutely. Because I told you that is the leading abuse in Oregon is financial exploitation.
And can we just clarify real quick? I didn't think APS was a voluntary program. APS's job was to go in and do the investigation piece.
It's a mandatory
voluntary.
Yeah. Yeah. APS is like a mandatory thing. It's not they have a choice to decide whether once we make a report, because we have it on the mental health side too, that you should investigate. Now, whether you can make a difference, that's another thing, but you have to go and look at the case and either substantiate it or not substantiate it or say it's not appropriate or whatever.